Well, hello everybody. My name is Mirvat Alasnag. I'm an interventional cardiologist practicing in Jeddah, Saudi Arabia. With me is Khaled, Al-Shaibi, also an interventional cardiologist practicing in Jeddah, Saudi Arabia. Hi, Khaled. And we're here excited to discuss with you day one of ESC Congress in London. Several guidelines were presented today, Khaled. The first was the Hypertension Guidelines. Do you think you can tell us a little bit about those?
Sure. Now, hypertension, as we all know, is the leading cause of cardiovascular, cerebrovascular morbidity and mortality worldwide. And these new guidelines address various aspects of management of high blood pressure. They address the how to go about diagnosing blood pressure, and there are actually 4 separate guidelines that go over how to measure blood pressure and emphasize the role of outpatient blood pressure measurements whenever feasible. There were also 6 new guidelines elaborated on the definition of high blood pressure, with the normal blood pressure being less than 120/70 and high blood pressure greater than 140/90, and a new category that is referred to in the guidelines as elevated blood pressure, and that is those patients that have a systolic blood pressure between 120 to 139 systolic over 70 to 89 diastolic. There were 10 new guidelines on the diagnosis that incorporates a global risk assessment as part of the diagnosis of blood pressure and guiding therapy. So in patients who are diagnosed with elevated blood pressure, that is, they're not normal and they don't quite meet the criteria for high blood pressure, incorporating this global risk assessment is key in deciding on when and what sort of therapy to initiate. Furthermore, 12 new guidelines on prevention and treatment were elaborated, and including for the very first time a recommendation pertaining to increasing potassium intake and reducing sugar intake as a part of a preventive strategy for high blood pressure. For elevated blood pressure, implementing a global risk assessment for those with a low risk score, an emphasis on lifestyle measures and follow-on. While those with elevated risk scores, pharmacological monotherapy with lifestyle modification and follow-up. For hypertensive patients that meet the criteria of blood pressure of greater than 140/90, the recommendation was starting with low-dose double therapy rather than monotherapy and progressing to low-dose triple therapy before escalating dose regimens. Also, provisions are made in the new guidelines for treatment levels to be guided by frailty, especially for those above the age of 85, in which lower targets can be set for diagnosis and treatment. For resistant hypertension, an emphasis on the addition of spironolactone and renal denervation in a shared decision-making process with the patient, provided it can be performed in a center with experience in the procedure, that is, medium to high volume centers, was discussed. So I think this is, in summary, the new guidelines highlights.
So the next set of guidelines were around the chronic coronary syndrome. These were much awaited, particularly by interventional cardiologists such as myself and you. But there was emphasis on addressing the traditional obstructive coronary artery disease, but they also focused on growing understanding of angina with no obstructive coronary arteries and ischemia with no obstructive coronary arteries as an important group of this clinical syndrome. A very patient-centered approach, again, was stressed with the treatment of lifestyle, modifiable risk factors, and anti-anginal therapies and revascularization. Class 1 recommendation for the uptake of cardiovascular CT in symptomatic patients, particularly those who are low to moderate risk. And of course, this is not unexpected. A Class 1 recommendation for functional myocardial imaging in patients with moderate to high likelihood of disease, probably based on ischemia trial and others. And again, and in spite of a lot of the controversy on physiology testing, there's a Class 1 recommendation for invasive angiography for patients with high likelihood of disease combined with physiologic evaluation, be it hyperemic or non-hyperemic indices. As far as revascularization for left main disease, that's probably the one area where there was significant controversy and debate. Nevertheless, the guidelines confirm that for left main disease, CABG remains a Class 1 indication, 1A, but for PCI, it's also recognized as a Class 1A indication for patients with low complexity syntax scores in whom a complete revascularization can be achieved. That's also Class 1A recommendation, and left main PCI for complex PCI, bifurcation disease, and long lesions is now required to have IVUS or OCT guidance. Now, revascularization also receives a Class 1A recommendation for 1 to 2 vessel disease that involves the proximal LAD, reducing long-term cardiovascular mortality and spontaneous myocardial infarctions. And as far as revascularization for multi-vessel disease with an ejection fraction of more than 35%, it receives a Class 1 recommendation for 3-vessel disease to improve long-term survival and, again, risk of spontaneous MI. In terms of the mode of revascularization, PCI versus CABG, the choice of revascularization strategy needs to be guided by the patient profile. So again, circling back to a very patient-centered discussion, the coronary anatomy, of course, and procedural factors as well as ejection fractions in these patients. So Khaled, the AFib guidelines came out. Yeah.
Okay.
So Khaled, the atrial fibrillation guidelines also were presented today at ESC. Do you want to give us a summary of that?
Sure. Well, as you said, they were presented this morning, and the key message was to emphasize the patient-centered integrated AF care approach, where C stands for comorbidity and risk factor management, such as treatment of hypertension, guideline-directed medical therapy for heart failure, with reduced ejection fraction, the 4 pillars that we all were aware of, Class 1 indication for the treatment of obesity, and the Class 2B indication for bariatric surgery, even in treatment of obese patients. Obstructive sleep apnea, again, quite common in this population, received a 2B indication for treatment, and exercise and reduction in alcohol intake, again, were all given Class 1 indications as part of the comorbidity risk modification in atrial fibrillation. The A in care is for avoidance of stroke and thromboembolism using direct oral anticoagulants, primarily guided by the CHA2DS2-VASc score, unless the patient has mitral stenosis or mechanical valves in which warfarin is indicated, again, receives a Class 1 indication. Again, we are required to assess and manage modifiable risk factors to reduce the chances of bleeding, but we're encouraged not to use bleeding risk scores to withhold anticoagulation. So use them to identify patients in which you can modify their risk of bleeding, but do not use them to withhold anticoagulation in these patients at high risk. Again, we're told this Class 1 indication, do not combine anticoagulation with antiplatelet agents for stroke prevention, and avoid antiplatelets beyond 12 months in patients with a need for oral anticoagulation with concomitant coronary or peripheral vascular disease. The R in the care algorithm stands for reduced symptoms by rate or rhythm control. Rate control is always the first step in these patients, and consider rhythm control with antiarrhythmics whenever the patient is defined as suitable for such therapy. Safety first for cardioversion. If the duration of atrial fibrillation is more than 24 hours, oral anticoagulation for 3 weeks, or transesophageal echo before cardioversion. Catheter ablation for AF now receives a Class 1 indication for paroxysmal atrial fibrillation, for failed antiarrhythmic rhythm control in patients in whom rhythm control is deemed appropriate, and for patients with AF and tachycardia-associated cardiomyopathy. Also entering the guidelines is a Class 1 indication for surgical ablation of AF in patients going for mitral valve surgery, and a Class 2A indication for atrial fibrillary surgical ablation for patients who are going for cardiac surgery, non-mitral valve cardiac surgery. And E finally in the algorithm stands for the evaluation, a continuous evaluation and a dynamic assessment of these patients over time as their risks and new modifiable risk factors arise. So a comprehensive patient-centered approach.
Wrap on the guidelines, but there were some hotlines and some important trials that I think we should be reviewing with our viewers. The first one was related to amyloid disease, the HELIO-B trial. Want to just summarize that for us, please?
Well, yeah, the HELIO-B trial, patient population was around 650 patients. Inclusion criteria included those who have the diagnosis of ATTR amyloidosis wild type or any TTR variant, confirmed cardiomyopathy with a medical history of symptomatic heart failure. They had to have New York Heart Classification heart failure class 3 or less, 6-minute walk of greater than 150 meters, and an NT-proBNP limit at baseline were assessed. Approximately 40% of the patients enrolled in this study were already on baseline therapy with tafamidis at baseline. Exclusion criteria included class 4 heart failure. The primary endpoint of the study was a composite outcome of all-cause mortality and recurrent cardiovascular events during a double-blind period of 33 to 36 months. The overall population included patients that were on monotherapy with this new agent, plus those on tafamidis in addition. So the overall cohort had patients on monotherapy with the new agent, plus combination therapy. The secondary endpoints were a change in the 6-minute walk test at 30, at 6-minute walk test at 30 days, in addition to the change in the quality of life score at 30 days. All-cause mortality at 42 months again was a secondary endpoint, as well as the change at 30 days in New York Heart Association class. The conclusion of this study is that this new agent reduced all-cause mortality and recurrent cardiovascular events in a contemporary population with ATTR amyloid cardiomyopathy that included substantial use of background therapy with current guideline-directed therapy. It also demonstrated significant benefits in multiple clinical measures of disease progression, as well as NT-proBNP. The results were consistent across all pre-specified subgroups, including patients on voltesiran monotherapy and those on background tafamidis. Safety and tolerability profile was consistent with the established profile for voltesiran. Rates of adverse events and serious adverse events leading to drug discontinuation were similar between active drug treatment in the placebo groups and were low. If approved by regulators, voltesiran has a potential to become the standard of care for newly diagnosed patients and those progressing on already established therapies. The greatest benefit really that needs to be stressed here, the greatest benefit we see in patients who were diagnosed early. So the earlier that you make the diagnosis and establish therapy, the better these patients do.
You know, another trial that was presented today again addresses a clinical dilemma that we see as clinicians, and it's really patients who had the ABYSS trial. These are patients, it was a multi-center, open-label, randomized trial that was a non-inferiority design done in 49 sites in France between 2018 and 2022. It had independent adjudication of all events, meaning death, MI, stroke, and hospitalizations for cardiovascular reasons. About 3,700 patients were enrolled in this trial with a median follow-up of 3 and up to 5 years. They included patients over the age of 18 who had a myocardial infarction more than 6 months prior to randomization and were on beta blockers with an ejection fraction of 40% or more. So, of course, those with lower ejection fractions and recent ACS or on beta blockers for other indications such as arrhythmias were excluded. The primary endpoint was a composite of death, myocardial infarction, and stroke, and as well as hospitalization for cardiovascular reasons. And then secondary was quality of life and blood pressure and heart rate control. The crossover rate was about 5.7%, more frequent in the beta blocker interruption group than those who continued, 8.6 versus 2.8%. The event rate in the beta blocker continuation was 21.1 compared with 23.8% in the discontinuation arm. The p-value for non-inferiority here was 0.44. And the driving reason for that was really cardiovascular rehospitalizations. So the ABYSS did not demonstrate the safety of beta blocker interruption in MI patients with preserved LV function, and a strategy that led to a higher rate of hospitalizations, actually, especially in hypertensive patients. And it did not improve quality of life, and in fact led to an increase in blood pressure and heart rate in these patients. And one more trial, again with clinical relevance to us, Dr. Khaled, was STOP or NOT the trial.
This trial looked at whether the continuation or discontinuation of renin-angiotensin system inhibitors before major non-cardiac surgery would result in reductions in major complications of 28 days. These are very commonly prescribed medications for patients with a variety of cardiovascular disorders ranging from hypertension to heart failure. So it's important, and this is a question that frequently comes up when patients are going for major non-cardiac surgery. Randomization was 1-to-1, with the group randomized to RASI discontinuation, having the drug withheld for 48 hours prior to surgery, versus those who were randomized to continue therapy. The primary outcome was all-cause mortality and major complications at 48 hours, such as major adverse cardiovascular events, sepsis, acute kidney injury, respiratory complications, unplanned ICU admission, and hyperkalemia. Not at 48 hours, I'm sorry, but at 28 days. So primary outcome, all-cause mortality and major complications out to 28 days. The secondary outcome was intraoperative hypotension, post-operative organ failure, hospital ICU length of stay. 1,000 patients were randomized in each arm of the surgery. 60% were major abdominal surgery, 20% thoracic surgery, and 20% vascular surgery. The median duration of surgery was around 3 hours. They aimed to include patients in which the planned surgery was going to take more than 2 hours, and they achieved that. The primary outcome was noted to be 22% exactly in both arms. No difference also was seen in any of the secondary outcomes. Intraoperative hypotension was, though, noted more frequently in the RASI continuation arm, but the duration of hypotension was very slight between the two groups. The difference was about 3 minutes additional hypotension in the RASI continuation arms, and this difference did not really translate into any clinical impact on the measurable secondary outcomes, and it's not thought to be of any significant consequence. And therefore, the conclusion was, in this multi-center randomized clinical trial, a continuation strategy of renin-angiotensin system inhibitors before major non-cardiac surgery was not associated with a higher rate of post-operative complications than the discontinuation strategy, making both strategies completely acceptable.
Well, that's a wrap of day one, and we'll see you day two wrap up.